Good morning, students. So, classes on Kala being taken for you. So, computer assisted learning. Till now, 4 topics have been covered. 5 topics. That is a general class about what is computer assisted learning. Then the other one was effect of drugs on blood pressure and heart rate of dog. Then the other one was Dale's vasomotor reversal. The next one was the normal DRC. In the fifth one, the effect of physostigmine on the DRC of acetylcholine on frog rectus muscle. So these were the 5 topics which are covered. So now the next topic will be effect of atropine on the DRC of acetylcholine on rat ileum. So the last one was on frog rectus. So this will be on rat ileum. So what is acetylcholine here? Acetylcholine is a sympathomimetic. It is a cholinergic drug. What is atropine? Atropine is an anticholinergic drug. So acetylcholine here, it acts on the muscarinic or the muscarinic receptors or the cholinergic receptors. So we have 5 types of muscarinic receptors, that is M1 to M5. Now atropine here, this is a non-selective anti-muscarinic drug. So this blocks all the muscarinic receptors, preventing the action of acetylcholine on the muscarinic receptors. So atropine here, this acts as an antagonist to acetylcholine. Okay. Then see this acetylcholine here, it is acting on the rat ileum. So what are the muscarinic receptors present on the intestine? So we have M3 receptors on the intestinal smooth muscle on which acetylcholine or atropine acts. So what is the action of acetylcholine on the smooth muscles of intestine? So there is increase in the contractility of the intestine and there are increased secretions, and the other thing is there is relaxation of the sphincters. So that when we plot on a graph, we see that when we give acetylcholine, there is increase in the contraction of the intestinal muscle as we increase the dose of acetylcholine. Then here atropine is an antagonist. So when you give atropine before giving acetylcholine, see normally first you plot a graph taking only acetylcholine. So after that you stop acetylcholine, give atropine, and then again you start giving acetylcholine. So you see that there will be a decrease in the contraction of the intestinal muscle. So we can see the antagonistic action of atropine. So this is just in brief about this. We will discuss in detail later about this experiment. So why I said all this is, so this is in general about what is antagonism. So now let us see what are the different types of antagonism. All this has been covered in general pharmacology. So since this is an important topic, we will be discussing again in detail about what is drug antagonism before going to the experiment. So the experiment will be dealt in the next class. So for now we will see what are the what is drug antagonism and what are the types. So here drug antagonism. So when one drug decreases or inhibits the action of another drug, it is called drug antagonism. See, the sum of the combined effect of 2 drugs will be less than the sum of the effects of individual drugs. Effect of A plus B, say atropine plus acetylcholine, will be less than the sum of individual effects. Effect of acetylcholine plus effect of atropine. So the combined effect of 2 drugs will be less than the sum of effects of individual drugs. So you can define antagonism as when one drug decreases or inhibits the action of another drug, you call it as drug antagonism. So depending upon the mechanism of action, we have 4 different types. So first one is physical antagonism, the second one is chemical antagonism, third one is physiological or functional antagonism, And the last one is pharmacological antagonism or receptor antagonism. So this is what we are concerned in this experiment here. So in detail, in brief about what is physical, chemical and functional or physiological antagonism. So physical antagonism, this is based on the physical property of the drug. See, take example, take charcoal. See, charcoal is used in different types of poisonings to treat different types of poisoning. So when you give charcoal, this this absorbs the poison present in the GI tract. So how does that do that? See, charcoal, it is based on the physical property of charcoal. Charcoal is a porous structure. This is negatively charged. So this will attract the positively charged ions or the toxic particles. So here in what poisoning we are giving here? Alkaloidal poisoning. So when we give charcoal in alkaloidal poisoning, this absorbs alkaloid, okay, and decreases the absorption of alkaloid into the blood. So this is forming a complex with the alkaloid. So this is physical antagonism. This is charcoal is antagonizing the action of alkaloid in the body by absorbing the alkaloid. Then next comes chemical antagonism. See here, when two drugs react chemically and they form an inactive complex. Okay. See, a type of antagonism where a drug counters the effect of another by simple chemical reaction or neutralization. So not by binding to the receptor, it is just a neutralization reaction where two drugs combine and they form an inactive product. So example for this is calcium sodium editate. So what is this calcium sodium editate? This is a chelating agent. So we use chelating agents in heavy metal poisoning. So how do they form a complex? So chelating agent, this forms an inactive soluble, mistake here. So this forms an inactive soluble complex with the heavy metal like arsenic or lead. So here the heavy metal is forming an inactive complex with the heavy metal. Chelating agent, chelating agent is forming a inactive complex with the heavy metal and it is used in the treatment of heavy metal poisoning. So other examples for this are, the next one will be neutralization of the gastric acid in our stomach by taking an antacid. Then one more is heparin, overdose of heparin. We treat it by giving protamine sulfate, which is an antagonist of heparin. So three examples for this. So when two drugs chemically react and form an inactive complex, we call it as chemical antagonism. Then comes the next, functional or physiological antagonism. See here what it is. Two drugs here, they act on different receptors as agonists. When two drugs act as agonists on different receptor, okay, but they counterbalance their effects by producing opposite effects. See, one drug produces one effect and then other drug produces an opposite effect to the first drug. Say drug A is producing a particular effect, then drug B will produce an opposite effect to that of drug A and then they will balance their effect. They counterbalance their effect. See, when two drugs act on different receptors as agonists and they counterbalance their effect by producing opposite actions on the same physiological system. See, this you can understand better with the help of an example. See, glucagon and insulin on blood sugar level. See, the common physiological system here is blood sugar level. Now, what is glucagon doing? This is increasing the blood sugar level. Then insulin, it decreases the blood sugar level. But they act on different receptors as agonists. They are agonists at that particular receptor. So glucagon and insulin, they're acting on different receptors as agonists, but they counterbalance their effect. That is, they maintain a normal blood sugar level. They don't allow it to increase or don't allow it to decrease. So there is a range of blood sugar level which has to be maintained in the body. So that is done by both glucagon and insulin. Another example for this is, see, histamine. Histamine produces vasodilatation, acting on blood vessels, histamine receptors on the blood vessels. Now, this is counterbalanced when we give norepinephrine, which acts on alpha-1 adrenoreceptors and produces vasoconstriction. So, the same physiological system here is the blood vessels. So one is causing vasodilatation, the other is causing vasoconstriction, and their site of action of receptors is also different. Histamine acts on histamine receptors. Histamine acts as an agonist on histamine receptors and it causes vasodilatation. Whereas norepinephrine, it acts as an agonist at alpha-1 adrenoreceptors and causes vasoconstriction. But norepinephrine is antagonizing the action of histamine by counterbalancing the vasodilatation. Okay, so is this clear? So these are two examples for this. Then coming to the next one, pharmacological antagonism. See, pharmacological antagonism is also called as receptor antagonism. So here we have two types of pharmacological antagonism. So one is competitive and the other is non-competitive antagonism. Again, in competitive antagonism, we have two types. So one is equilibrium or reversible competitive antagonism. The other is non-equilibrium or irreversible antagonism. So we will read this with the image. So this is first competitive or reversible. This is a reversible competitive antagonism. So first this image just explains about competitive antagonism. Then we will see what is reversible, what is irreversible. Competitive antagonism is when an antagonist competes with the agonist for the same receptor, then we call it as competitive antagonism. Here the antagonist is competing with the agonist for the same receptor and this prevents the binding of the agonist with the receptor. So that is a competitive antagonism. So here in this we have two types, reversible competitive antagonism and irreversible competitive antagonism. Reversible competitive antagonism is here the antagonist, it binds with the receptor but it forms weak bonds. So it is easily displaceable by increasing the concentration of the agonist. See, same receptor, antagonist binds to the same receptor by forming weak bonds. So maximal response of what? The agonist. Maximal response of the agonist can be attained even after giving an antagonist by increasing the concentration of the agonist. So that's why we see here maximal response is concentration dependent. Maximal response of the agonist is concentration dependent. Then the effect of antagonist here can be overcome by increasing the concentration of the agonist. Now if you see the DRC here, there will be a parallel rightward shift. So there is a parallel rightward shift. It's towards this side, shifting towards this side. So here this first DRC is a DRC for the agonist alone. Okay, see acetylcholine. So example for this is atropine and acetylcholine at muscarinic receptor. One more is naloxone and morphine at the opioid receptor. See, acetylcholine is the agonist at the muscarinic receptor. Atropine is the antagonist at muscarinic receptor. Similarly, morphine is an agonist at opioid receptor and naloxone is an antagonist at the opioid receptor. So if we see here, take for example acetylcholine. You consider here the agonist is acetylcholine. So when you take acetylcholine alone, this is the DRC for acetylcholine alone. So now next, before giving acetylcholine, you give atropine. So now if you have to attain the same maximal response, so what you should do, you should increase the concentration of acetylcholine. So this is the concentration. On x-axis we are plotting the log dose. On y-axis we are plotting the effect. So now if you have to get the same effect along with the agonist, you have to increase the concentration of the acetylcholine here because you're giving the antagonist atropine. So you see that there is a parallel rightward shift of the DRC. So you need an increased concentration of atropine to produce the same maximal response when you're giving acetylcholine alone. So the next one will be, you're giving more antagonist, more atropine you're giving. So then what do you need to do? You need to increase the concentration of acetylcholine even more. So there is a further shift in the DRC curve. See here, it will be a even more higher concentration of acetylcholine. So now you need this much concentration of acetylcholine again to produce the same maximal response when you were giving acetylcholine alone, because here you are giving an increased concentration of antagonist, that is atropine. So is this clear? So there will be a parallel rightward shift of the DRC to attain the same maximal response when you are giving an antagonist. So this is about reversible competitive antagonism. Next is irreversible competitive antagonism. So here the difference is that the antagonist, it binds to the same receptor as that of the agonist, but it binds irreversibly. It is irreversibly by covalent bonds. So you cannot, the effect cannot be overcome even by increasing the concentration of the agonist. Or in other words, what you can say, the maximal response here is not concentration dependent. Maximal response of the agonist is not concentration dependent. So you, by increasing the concentration of the agonist, you can't overcome the effect of the antagonist. So what will happen to the LDR curve? The LDR curve of the agonist would show the reduced efficacy with unaltered potency. The potency remains almost unaltered. There may be a very slight increase in the potency, but you can see that there will be reduced efficacy. See this curve here. So this first curve is for agonist alone. So since this antagonistic action is irreversible, when you're giving an antagonist, so you want to produce the same maximal response. So you increase the concentration of the agonist, but still you cannot produce the maximum effect because the antagonist is irreversibly bound to the receptor. So what happens? The response of the agonist decreases. So you can see that there is a decrease in the response of the agonist. See here, it is written agonist plus irreversible competitive antagonist. So next one is, you will increase the concentration of the competitive antagonist even more. So you see that there is a further drop in the height of the curve. There is a further decrease in the maximal response of the agonist. So you see there is no parallel rightward shift here as you've seen for the reversible competitive antagonism. It is just that there is a decrease in the height of the curve because there is decrease in the maximal response. So this is about irreversible competitive antagonism. Then coming to the next one, non-competitive antagonism. So here if you listen carefully, non-competitive antagonism is almost similar to irreversible competitive antagonism. Only difference is that there the antagonist competes with the same receptor site as that of the agonist. Here the antagonist, it does not compete with the same receptor site as that of the agonist. Only that is the difference. Otherwise the rest of it is same. See, I forgot to tell you the example for irreversible competitive antagonism. So one is, the example is debenamide competes irreversibly with norepinephrine at alpha-1 adrenoreceptors. This is an example for competitive irreversible antagonism. So here, non-competitive antagonism. So what happens here? The antagonist, it does not compete with the agonist for the agonist receptor site. So you see that the antagonist is binding at a different receptor site. Okay, so then what does it do? It alters the shape of the receptor where the agonist binds. So it is altering the shape. By binding here, the antagonist is binding here. So here the antagonist is binding to the receptor and it is altering the shape of the receptor where the agonist binds. Okay. So it is not competing with the receptor as that of the agonist. So here you can see that the shape of the receptor is altered and the agonist is not binding to the receptor. So what happens to the curve? what happens to the curve? So you see that there is a decrease in the response. Similarly, as you have seen with irreversible competitive antagonism. So even though you are increasing the concentration of the agonist, you can't overcome the antagonism, because antagonism is not competing with the agonist itself. It is binding to a different receptor. So there is no point in increasing the agonist concentration, because antagonist is not competing with the agonist. It is totally binding to a different receptor here. So even by increasing the concentration of the agonist, you can't overcome the effect of the antagonist, and you see that there is a decrease in the maximal response. So this curve is almost similar to that of the irreversible competitive antagonism. See, the only difference between non-competitive and irreversible competitive antagonism is that the antagonist, it binds to a different receptor than the agonist. In irreversible competitive antagonism, the antagonist competes with the agonist for the same receptor site, but it binds irreversibly. Here it is antagonist, it binds to a different receptor. It does not compete with the agonist, but it is altering the shape of the receptor to which the agonist binds, and it is preventing the response. So example for this is flumazenil, which is an antagonist of benzodiazepine. So flumazenil binds to a different receptor and alters the benzodiazepine receptor binding site. So the GABA, it cannot bind to the receptor and it blocks the effect of GABA. So flumazenil, which is an antagonist of benzodiazepine, is an example for non-competitive antagonism. So hope this is clear. So now what we are concerned here is atropine and acetylcholine. So that is competitive reversible antagonism. So the experiment which we will see on Monday, so that will be an example for competitive reversible antagonism. So the question will be, the graph will be on effect of atropine on the DRC of acetylcholine on rat ileum. So in the next class, we will discuss about this. So little before that about normal DRC and interpretation of the log dose response curve. How do we interpret it? Then we will come to the experiment and we will discuss it. So for today, just go through antagonism. Just be clear with the concept. What is competitive reversible? What is competitive irreversible? Then what is non-competitive antagonism? Thank you.